this webinar hosted by Waterlase MG. We are excited to have our special guest, Dr. Brad Labrecque, with us today. Dr. Brad is one of Waterlase MG's key opinion leaders and is a pioneer in the Waterlase industry. His experience has helped many Waterlase users and done a tremendous amount of trainings. So his insights are going to be very, very great to hear. We will have a Q&A session at the end of the presentation. So please feel free to submit your questions in the chat throughout the webinar. And within the last 10, 15 minutes of it, we'll go ahead and answer all those questions. But for now, Dr. Labrecque, thank you for being here. And the audience is all yours.
Thank you very much. And welcome to everybody. It's a great honor to be able to have a discussion with you on something that I think is a lot of fun. You know, what are things that we can do with this Waterlase that we have sitting in our corner of our office? Where can we make use of it the most? So we're going to focus really a bit on the erbium laser removal of crowns and veneers. Like, does it work? Does it not work? How can you be more successful with it at that point? So at this point, I'm going to spend some time talking about interaction with the restorative materials in cement. We're going to review some indications. When's a good time to do it? When's a bad time to do it? Talk about certain settings. I know that everybody wants a setting. I know you can. Just give me the setting. Just give me the setting. There's more than just having a setting. You have to understand how this laser works. And we're going to talk a little bit about how that is. We know that this does not damage the pulp integrity of the tooth. Okay, right off the top. Okay, and that is from there. So, and we'll hopefully get through there, and then we'll have questions afterwards. And so, as myself, I just want to let you know quickly. I'm not going to spend too much time on this, of course. Is that in private practice in Laguna Niguel, California, right now? And at that point, I spent my career, which is spanning some 43 years right now. 36 years has been with the laser. I've taken not just one course. I've probably taken over 10,000 continuing education courses and trainings and getting a mastership to understand why these lasers work and how I can make them work the best way. And within the next 50 minutes, I'm going to try and give you as much information as I can on that portion and manage from there. So we'll move along and stuff. So why would you want to use the erbium laser? Well, let's compare it to what we're traditionally would do. Traditionally, we're going to pick up a front teeth. We're going to start cutting on this zirconia and the tooth, and we're going to create some heat. We may not be able to control once we get through. We might fracture the tooth. We might do other things. So at that point, is there a better way, especially when we're trying to remove veneers and zirconia materials that which we work on? Of course, they're not going to work on gold. They're not going to work on TFMs because light is what you're working with. And as working with light, it has to be transmitted through something and managed from there. So just briefly, just to let you know where you're at. And I was blessed because I've been in dentistry so long that this guy told me everything I needed to know about energy and how he managed it from there. So what I'm going to show you here is a spectrum of light. You may have seen this before. You may not have, okay? But let's look at where we're at. We're talking about working in the infrared zone. We're talking about now working in the mid-infrared zone. That is the erbium lasers. That's where they live, all right? An erbium laser works with water. Why does it work with water? Well, basically, it's absorbed by water. And it's also absorbed by hydroxyapatite, which you can see on this graph. So anything that has water in it is going to be absorbed by this laser. If it's dry, it's not going to get absorbed. So part of the reason why we have a Waterlase is that we're providing the water to do the job that we need it to do. However, the materials that we have the laser energy getting absorbed in has water molecules as well. So when we're talking about veneers, crowns, and the like, the veneer doesn't absorb anything. The veneer has to transmit the light through, and then it finds the cement layer. The cement layer is a hydrated layer. That's where the laser works. So now we have to make sure that we get the energy to where it wants to work. That's the basis. What else has happened? This Waterlase, if it removes caries before it removes healthy dentin. All right? It removes calculus very quickly and easily without having to scrape and pulled and do all these other things that we do with traditional instruments. This is another instrument in your hands that we're going to learn how to use better and better the more you use it as well. So there's only two common lasers in the area. We're working with the 2780 YSGG laser. That's the other laser is the erbium YAG laser, which is a 2940. Let's just go back for a moment. As we look at that, the difference in the two lasers is basically how they're absorbed by water. They're both being absorbed in a substantial amount. If one is being absorbed a little bit more when we're talking about removing crowns and veneers, is that an advantage? Yes and no. All right. It doesn't matter too much because Waterlase are providing enough water to make that job. So our indications are going to be for porcelain veneers, lithium disilica crown, zirconia crown. We might be able to remove some inlays or onlays with it. We can also consider using it if you're getting access through some restorations as well, because now we can remove the crown before we do our endo. All right, contraindication. It's the big part of it. How much thickness can the laser go through? As we mill and prepare teeth over the years, zirconia restorations are sometimes not the 1 to 1.5 millimeter. They're 2 plus. Is there enough energy that can be transmitted through that? Well, let's figure out if we can adjust the energy to maximize it. Metal-based crowns, of course not. As soon as the laser energy hits the metal, it rebounds back. No, unpopular. So PFMs, gold, amalgam restorations, no. All right. As far as training, I mean, you just have to make sure that you understand, and I'll give you some information today on how this laser moves forward to do the job that we want it to do. And then you got to practice it. All right. I mean, you have to practice it and start slow and move our way up on there. All right. Everybody has a Waterlase. We're going to learn about tips. We're going to talk about eyewear protection, of course, that's necessary. We're going to talk about how close do we have our evacuation. You're working with a Waterlase. It's water. It needs the water to work. If you're having any sensitivity issues when you're working with your laser, even when doing restorative work, it's because you shouldn't hold the high volume suction beside the surgical site. You should hold the saliva ejector beside the cervical site. That's what you want to do. And that is there. If you're pulling the water away, the laser automatically is going to create some heat. The heat will cause some sensitivity. There is one little pearl that I could give you right off the top. Magnification. I'm hoping that all of you are using loops at some point in time and you're working with your two with this, managing it from there. So when we look at a setting, I can break it down into various. I try to break it down as going, we have energy, which is our watts, and then we have a pulse per second, which is our hertz. This gives us our power. And now if you've taken some later courses that we're running, we talk a lot about millijoules. And if you have the most recent software on your Waterlase, we have now indicating how many millijoules is coming out of your handpiece. Now, other than that, we need to know tip. We need to know handpiece. We need to know how much air and water is necessary for this procedure. We need to know what angle should we hold the handpiece. And we need to know how close should we be. Another one that I should maybe add to that is how fast do I move my hand? Because at that point, sometimes over the years of training dentists along the way, is the fact that we all move too fast. We don't let the energy get absorbed. And if you don't let the energy get absorbed, how are you supposed to let the laser do its job for you? Okay, so it's kind of a catch-22 in that area there. So tip-wise, again, which tips are we going to be using? Well, we're certainly not going to use a side firing tip to take off a crown or veneer. It's useful for removing calculus. It's useful for cleaning an implant. The radial firing tips are useful for endo and perio, but not for this. We're going to use a gold handpiece, we're going to use an end firing tip. Okay, we want to have the energy directed directly to where we want. But which tip do we need? Well, in this case here, we're holding the handpiece above the tube, and it's at a certain distance, which is our focal length. And as we work through our focal length, you'll see that it's going to start with the video. If it works properly, we'll start to break through the area. Ooh, it's not working as good as I hoped. Starts to break down the enamel here. That's what I was trying to get at there. So is it work? It's a working distance. So let's talk about power. Okay. With power, we're talking about hertz. I mean watts, pardon me. Now, if we take that watts and divide it by times it by 1,000, divide it by hertz, that tells us how many millijoules we're working. So in dentin and enamel, okay, we would do enamel, we need about 450 to 600 millijoules. Dentin is about 300 millijoules. Caries, again, is 50 to 150. Bone is 120 to 150. Soft tissue is 60 to 80. And calculus is 50. This is our window of what we want to work with to manage the. So if we're talking about removing a crown or veneer, we're going to start thinking about somewhere between 450 and 600 millijoules. So where do I usually go on that? I usually go to class 1, rapid, and start making some adjustments from there. All right. The erbium laser itself is ablative, non-thermal. It's going to remove infected tissue first. It preserves the osteocyte. It's bactericidal. It does stimulate osteoblast and fibroblast growth factor release. It does remove a smear layer, finds a path of least resistance, which is photoacoustic screening, and is minimally invasive compared to traditional therapy. There's an advantage from there, just to give you some ideas of what you're working with. Some people forget all this stuff. So let's again apply this system here. In the veneer removal protocol, we're going to use a scanning motion across the veneer. We're going to have to keep the water spray now. We want to keep the water spray when we're working on hard tissue, which includes also enamel and bone, somewhere around 90%. This makes sure that we have enough water so we won't create any heat. Okay. We want to move slowly. We don't want to hold it in position, but we want to move slowly to let the energy get absorbed. And so we start swinging back and forth. And I like to start from the gingival margin and work my way up. When we're doing a veneer, you start to see some color changes underneath the veneer. That indicates that the cement is getting colored, is being absorbed, and does create a little bit of heat. Sometimes you see a bit of darkness when the cement is getting energized, okay, at that point. Then once we've kind of covered the whole surface, buccally, try to get a little bit interproximally, then usually a sickle scaler is used to remove it if it hasn't fallen off in one spot there. Now, depending on the fact that do we want to take it off to re-cement it, or do we want to take it off and just restart reprep it? Then we adjust the energy of watts accordingly, because if we go to a high watt, let's say 600 millijoules at the highest setting, the veneer will crack. If we reduce the veneers removal down to about 400 to 450, we can usually remove the veneer. And then at that point, let's say it was a poor bond or something, you want to change it. That's what I would do. So, and again, at this point, this is what's in your system. It's going to say watts. It's going to be 4 to 5. It's going to have hertz, about 10 to 15. We can use a tip, or we can I'll talk about the turbo in a moment. Our water, I said between 80 and 90, and our air should be about 60. All right, and it goes quick. Removal of a veneer is generally pretty good. So again, what I'm suggesting when I do a veneer, based on my experiences, is especially veneers are usually 1 millimeter or less and stuff. I like working between 400 and 450 millijoules, which is 4 watts at 10 hertz, or 6 watts at 15 hertz. So as you're hearing that popping noise moving along, you kind of move slowly and let those popping noises kind of go pop, pop in one spot, pop, 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 pop. And, have at least 2 transmissions of energy out of the handpiece in one position to move on. And don't sit there and wave it so back and forth so quickly that nothing much can happen. All right. Just to give you an idea, when we actually can make some changes in a setting, is that if I had a setting here, which is I wanted to work at 400 millijoules, and that 400 millijoules is what I want to use to remove the veneer, I could go 8 watts at 20 hertz. I can go 6 watts at 15 hertz, 4 watts at 10 hertz. Okay. There's so many variables in that point when my endpoint is 400 millijoules. And that's a very important equation for you to understand, is that if you can manage that, and if it's nothing's not being successful, well, why would it be better to be 8 watts at 20 hertz or 4 watts at 10? We have the same amount of energy at that point, but at a higher energy rate, we might have a quicker, deeper, faster penetration through the material at that point, which is kind of helpful when we are working there. I don't like personally to work at 8 watts. Why? That's a really high power. And if you've ever had any issues with your laser, sometimes the trunk fiber gets a little bit overused, and that can be an issue to the trunk fiber. So I like to maintain everything at the highest power setting I ever go to is 6 watts at 15 hertz. All right. So with the tipped handpiece, which you're all familiar with, there's 3 different tips that you can work from. You can again now have a look at the MZ5, MZ6, and MZ8. The MZ5 gives us our best depth of penetration. All right. So coming out of the handpiece, coming out of the fiber, the energy hits from the fiber to the mirror and the handpiece to the tip. That gives us the best penetration. It's the most efficient cutting tip. It'll give us the best depth of absorption. As we get wider, what happens is the energy gets spread out, so it doesn't go as deep, right? Okay, not a lot of difference between the MZ6 and the MZ5, slight, okay? But when we move to an 8, well, again, you would use that on something that's very, very thin in the veneer area. I wouldn't use that on a zirconia crown. All right. I would on the zirconia crown, when we get to move on to that, I would want to use something like an MZ5 or MZ6. All right. As an offshoot, let's say you're doing some restorative work on a class 5, I would use an MZ8. The MZ8 has less depth of penetration, so less possible uh, stimulation of the pulpal nerve to cause any sensitivity if you're doing something non-anesthetic. And if I want to control my depth of penetration, then I think that an MZ8 is a better route to go for that. Okay, so the tip, again, keep a tip in good shape. All right, being the workhorse that we call it is, you're going to use one for that's probably about 6 millimeters in length. Honestly, if it isn't nice and smooth at the end, and check it with your loops, or also if some of you still have the tip checking microscope that came with your kit, make sure that it's not breaking down on the edges. Because as soon as it starts breaking down on the edges, you've lost the focus point of the tip, and it's not going to work as good. All right. So again, managing the integrity of the tip between procedures is super, super important. Okay. And again, the difference between 0.5 and 0.6 millimeters is not much. And so each of them can be used interchangeably. All right. And as we look again over in this zone here, that if you see what we're looking at managing from here on the MZ Gold, we have an MG6 tip here and an MZ5 tip there. And we can see that our power density is a little bit higher at the surface with the MZ5, which is manages, gives it this matches up to this diagram right here. So hopefully understanding tips is important and managing it from there and understanding which one. Now the turbo handpiece is totally different. Okay, that's the tip. If some of you have never worked with a turbo handpiece, you kind of go, oh, well, it looks kind of tipless. Well, it kind of is. We can call it tipless as well. With that tip, we don't have to be as close to the surface. Okay, I mentioned there, we can be somewhere between 3 to 5 millimeters. And again, you're kind of watching how the energy is affecting the surface. That's how you pick how close you should be. It's It's useful. Okay, I like it. I use it quite a bit in zirconia crown removal because it's sometimes a little bit easier to get access to the posterior with this as well. And I can run a little bit more power through it, as you'll see in a moment. Okay, so that's what it looks like. You really depend when if you haven't worked with the turbo before, you really depend on the aiming beam to get you to find out where you're going to get to that optimum absorption or cutting position. Okay, so when we compare the two together, at that point, you can see again, we can turbo handpiece is going to be a little bit further away from the tissue. You want to stay within a half a millimeter to a millimeter and a half with the MZ5. And you just kind of don't just say that, but really watch what the energy is doing to the surface that you're trying to do. At that point, then you'll know where if you're close enough or not. You got to find that focal point. You've all worked with magnifying glasses before. You all know what's happening. If you kind of get it just right, you get that focal point just right, you can start to burn a little bit on the wood, carve your initials somewhere on a tree, or cook a few ants along the way. Well, that's kind of where we're at here, is that you want to take the time to find the focal point before you start moving around. Slow down. Watch what you're doing. Let the guide. What's guiding you is the energy and the light, not your handpiece. All right. A lot of us, because we start working with this, we start moving our hands around so quickly because we think we have a high speed in our hands, and we just don't. So again, you have to slow yourself down. We always say move around 1 millimeter a second. Another way to kind of look at it is because you know you're at 10 or 15 hertz, is that as you're hearing that popping noise, hold still, let it pop for 2 to 3 times before you start to move to the next position, and that will slow you down as well. I use that quite a bit when I'm doing various procedures in endo, all right? Or if I'm doing perial pockets, I stay in the canals and the pockets and I focus my time. All right. So again, the quality of the aim beam is taken care of by the tip, handpiece, water, air, the angulation, which is pretty much going to be at 90 degrees, and the working distance, which I'm telling you to find that focal point. So the case here with this veneer removal here. Oops, excuse me. Go back. All right. As I'm moving here, you can see I'm starting at the margin, and my video is a little jerky today, but I am trying to hold still. But in this case here, I'm working at about 5 watts at 15 hertz, and I'm not too concerned about keeping the veneer in good shape. So at this point, it fractures, and that's okay. I start to see some changes underneath that area. Let's bring up the other video because hopefully it is gives us a better result here. Oh, for peace sake. You can see the changes underneath the veneer here. And at that point, as we get to the end of the video here, I picked up the sickle scaler and able to remove it. There we go. My apologies for the way the video is working today. It must be something going on there. Try this one here. Okay. All right. I wish the video was better. I apologize for that. Excellent candidates are Emax crowns and Emax veneers. Also, no prep veneers come off super, super quick and easy. All right. And so I would use the no prep veneer. I would work at somewhere around 4 watts at 15 hertz. And if I was working at Emax crowns and Emax veneers, they're a little bit heavier, I would start thinking about going at about 4.5 watts at 10 to 15 hertz as well. All right. If we start looking at the zirconia crown, zirconia crowns are thicker. Because they're thicker, they need more energy. They also need us to slow down even more because we have to make sure the energy gets through at that point. Because the zirconia has some degree of opacity and it starts to block the energy from going in if you move too fast. Okay. The focus is on the margins and the axial surfaces. All right. And we keep our air and water very high, keep the high volume suction away so we're not generating any heat. Okay. Those are the three main things to watch for there at that point. So again, 80 to 90% cooling, working from 10 to 15 hertz is the better. And we can adjust. The slower the hertz rate, the more power per pulse. The higher the hertz rate, less power per pulse. So the energy doesn't penetrate as deep. Now, the situation is that if I could use a turbo handpiece in removing some zirconia crowns, I like that because at that point, I'm able to work more comfortably sometimes at a higher millijoules rate of around 600. How do I get to 600? Well, that is 6 watts at 10 hertz, or that's looking at 8 watts at 20, 15 hertz. Okay, so again, the handpiece is important, working the same distance. So again, here we are working at 10 hertz, 600 to 700 millijoules is where I like to be. I used an NV6, not an 8 anymore. I found that the 8 didn't penetrate deep enough. And a turbo handpiece, if you do have one, I use an MX9. Okay. I spend somewhere between 3 to 4 minutes working on there. If the thickness is more, I might have to spend a couple more minutes. Then hopefully I will get the results that I want. And then from there, I can grab it with a crown removing forcep at that point and luxate to the point that hopefully it'll pop off. Sometimes it just pop off in one shot. So in this case here, we're starting at the margin and moving up. Now crowns or 3/4 crowns will not break down. They will not crack because they're all in one position. So they'll come off in their entirety. So if you are thinking about taking off one of these to do endo, then you can re-cement it right after your procedure. And there's the crown removal pliers. You may have seen those. You may have them in your office, and you can pull it off. Again, now this is done with the turbo handpiece. Now you can see the turbo, we're much further away as I'm moving. So again, at this point, we can run a little bit more power through the turbo handpiece because there's less chance of any reflection and irritation to our fiber. Some people like the turbo handpiece to do a lot of their class 1 restorations as well. They find that it breaks down tissue better when we're removing enamel. But you can see the distance of focal distance is controlled. At this point, we're removing the occlusal. We got the occlusal surface now. Okay, in this case here was a small pedo forcep that the doctor used. And there you go. Success. All right. Zirconia are much more challenging because they're greater opacity. And so we get less energy going through that area, so we have to keep our power set up. So it takes a little bit longer. Okay, it requires maybe multiple passes. You might not get it done all in one shot. And so patience is kind of required, and then you just have to determine, okay, is this long enough or not? Like I said, I give myself, 3 to 4, sometimes 5 minutes to get it off, especially if I'm doing something I want to use the crown for. If I'm not reusing it at that point, then I will pick up the high-speed handpiece and I will start to place a small buckle groove on the surface. And a lot of times, when you're putting that extra little pressure with the handpiece, seems to loosen it up right away. All right. And so then it is still a little bit less work than cutting it all off. Okay. You want to keep moving when you're doing this. You want to keep moving continuously. Okay. Overlap the energy. Okay. Try to keep it as you're moving so that you're kind of moving along and, overlap the energy profiles by at least 20%. All right. As you made one pass, grab if you're doing a veneer, grab a scaler. If you're doing a crown, you can kind of grab on with whatever crown removal tool you want to use, luxate a little bit and see if it will move. If not, then do another pass and do another pass. All right, and manage from there. And I think keep the high volume system away from the area. I mean, if it's not working 100%, the energy has started to break down the cement in a certain way, and it will make what the more traditional therapies easier. Okay. So as I put it together, I find that for lithium disilicate and feldspathik veneers, I mean, it's pretty much a no-brainer. It's going to work pretty much 100% of the time without any trouble. Hybrid ceramics that you may be using with some zirconia maybe are good as long as you don't have too much thickness to them. We know a PFM is 0.0, and the zirconia itself is moderate success. Am I going to tell you that you can get everyone off 100%? The answer is no. All right. However, I give it a good shot at the beginning to see how it goes, especially sometimes when I have a zirconia bridge where maybe one of the abutments is loose and the other isn't. Okay. We're quite hard on the posterior abutment to remove it so we can give another recementation at that point. Okay. I came across this. A robot just completed an entire crown prep. Does that mean that we are going to be replaced by our AI compatible friends? I hope not. But I can tell you right now, the advantage of teaching a robot how to use a laser compared to a human doctor is that I can tell the robot how fast to move to let the energy get absorbed. So maybe the robot will be able to work with the laser better than we can. All right. Of course, when we're doing this, I want to make sure you know that your patients are going to wear the laser specific eyewear to the wavelength that you're using. Okay. We're going to try and keep away from the surface of the soft tissue because we're using high power, which will manage the problem. Okay. The high volume vacuum is not beside the surgical site, but you can hold it up away to catch any overspray. The pulpit temperature, if we keep the water high in temperature, will be a non-issue. And I always recommend that you document your laser settings in your chart notes. And I just feel that is a good position. So especially if you kind of can see that worked really good on that last patient, but I can't remember what I did it with. Then I go back and you can have a look to see where you're at or manage it from there. Okay. Pulpal safety, temperature increases generally. below accepted injury threshold. Water cooling is critical. So keep your water turned to about 80 to 90%. Okay. Potential complications, of course, are, hey, we have some incomplete bonding. You might leave some material behind. That's okay. The cement is going to be left behind to a certain degree. You're going to have to pick up a high speed to kind of polish the prep before you resubmit. Okay. The fracture of the restoration could happen. More so, we see this in veneers as opposed to crowns. Okay. But if your idea is you want to save the veneer, keep the power level low, so it will increase your time, but you still should be pretty successful. At that point, though, always let the patient know there's always a chance this might happen. But there's less chance of it happening than if you did it with a high speed, because it always happens. All right. Heat generation is controlled by keeping your water temperature high and the high volume away. Soft tissue injury is kept there because just don't aim at the soft tissue. And then because sometimes some zirconia are thicker and that sort of thing, it may say, hey, maybe it's not, after a period of time, this isn't the right tool for this restoration. Like I said, for zirconia crowns, it's not 100%. There's some great literature review out there. I mean, these studies support many different aspects of removing tissue and of the zirconia the zirconia restorations at that point. We also know that, everybody has various successes with this. I'm trying to give you some settings at this point that will help you be more successful. But it's really important to understand is that you can adjust the hertz and the power to maximize what's good for that particular restoration and that particular patient and that particular procedure. And as long as you stay within the guidelines of the millijoules for various procedures, and once you learn how to determine your millijoules properly, then I guess you can move these settings to be more successful for you. Don't think just you pick it up and it has to be that setting. All right, and go from there. Okay, so as we're getting closer to the end here, is first of all, I need to apologize. I'm not too sure why my downloads of the videos are so broken up. I've never seen that before from the same position. So I'm not too sure what happened there, but my apologies for that. The take-home messages here is that laser debonding targets the cement, not the veneer, not the material itself. We want it to target the cement. So we have to move slow enough to let the energy get through the veneer and the crown to get to where you want to go. Veneers, lithium disilicate restorations are the ideal cases for this. They come off pretty about 90 to 95% of the time, as long as they're not too thick, and that managed from there. Zirconia, you need a bit more patience with it. It's a little slower. Like I say, I give myself 3 to 4 minutes, sometimes up to 5, manage for them to get the success I want, and I need more power. So again, with the zirconia, I'm working maybe with a turbo handpiece. I'm working more than 6 watts at 10 hertz. But at 10 hertz, you got to move slow because you only have energy coming out 10 times a second. So if you move too fast, you're going to hit one spot or the distal and you move over a bit more, and you might hit one spot in the buccal and another spot in the medial. So again, hold the handpiece still and kind of hear those pops going like 2 pulses, and 2 pulses, and 2 pulses, and 2 pulses will move you in an area that will be slow enough. All right. It's all about controlling the movement to allow the energy to be absorbed. We're not working with a high-speed handpiece anymore. The laser light is the tool, and so the light does the work, not anything else. All right. And your technique is huge. Okay, if you move too fast, which always is, I work with doctors over the years, trying to get them to get the procedures done the way I want them to do it, and we sit down together. It's always pretty much 9 times out of 10. It's not very successful. And then I go, okay, show me what you do. And then I can see that you're moving too fast. let's say if you're working on soft, just to give you an idea, if you're using your laser to do gingivectomy or trophy, and you have the ability that you can say, hey, my laser, I keep on getting bleeding. I don't understand what's going on. 9 times out of 10, you're moving too quick. You're not letting the laser energy, which creates a minimal amount of heat just because of the nature of the absorption in water of 1 to 2 degrees centigrade, to give you the hemostasis that you need as you move along. So if you don't allow that to happen, you're going to have bleeding, and that's going to be very frustrating. Okay. You need to work smarter, not harder. The lasers over the years has been a very great tool. I've enjoyed using it every day on pretty much every procedure, one way or the other. I figure if I spent that much money having one in my practice, and I don't want, there's no such thing as a laser procedure. There are many, many procedures that I can do as a, as part of the procedure. It might not be the only tool, but it's a good tool to add to what I want to do. Like I'm not going to remove the crown and re-prep it with laser. That'd be ridiculous. I'm not going to do the same thing with a veneer, but I'll remove the crown and the veneer atraumatically, and I'll save myself about 4 or 5 diamonds at the same time on my hand pieces. All right. So some of the Waterlase benefits that maybe just going to refresh your memory on here is that it's, first of all, it is minimally invasive. If we are using Pearl and Overjet to aid in our diagnosis of decay, we are diagnosing minimally invasively. If we're diagnosing minimally invasively, we need to treat minimally invasively. Makes sense. So let's start thinking about using our laser. If you're identifying an interproximal decay and on Pearl or Interjet, it says that it is 50% incidental or maybe even 10%, but you want to do it, your laser should be your primary tool, not a high speed, because you're going to cause more collateral damage to the high speed. So you're better off just leaving it get bigger. Isn't that why we used to say watch it all the time? But now we don't want to watch it. Same thing goes with periodontal pockets. When should you treat a periodontal pocket? Do you treat a periodontal pocket when it's 8, or you should treat it when it's 5? Well, if you're losing bone, the sooner you treat it, the better. And the more sooner we get into it, the less chance of any progression of the disease and more chance of bone regeneration. We know every time we pick up the laser, it's bactericidal. We know that it can initiate dentin repair faster than calcium hydroxide on basis. It does increase fibroblast attachment. Why? Because it stimulates cell growth. Remember that the laser energy is stimulating the mitochondria of your cells to stimulate more ATP, increases blood circulation in the area, and at that endpoint and stuff like that, you get better cell growth. Are you still putting blue etch on your teeth before you bond? Did you remember that your laser has a laser etch setting that you can remove the smear layer more effectively and more completely, and you can open up the dental tubules more, which will improve your bond strength because now you'll have longer resin tanks. If you're doing soft tissue surgery, and some of you may have done some frenectomies or lingual tongue releases or gingivectomies, there's really no irritation of inflammation after the procedure, and you start to see tissue regeneration and repair much quicker compared to traditional. If you have a Waterlase in there in your practice and you're doing endo and you are not using it, you're missing out huge. If you're not using it for endo, please take an endo course. Understand that you need to understand how to make that laser work good. And of course, and maybe at some point we'll have a webinar on endo as well. Soft tissue control, again, with gingivectomies, frenectomies, fibroma removals, and the like. It should be your first tool of choice. It does a better job, it heals quicker, and you can use less anesthetic at the same time. All right. So a lot of procedures over the years that I've done in my practice, I wouldn't have done very well, or I would have stayed away from them, especially tongue releases. Oh my goodness gracious, I couldn't imagine doing it with a with a scalpel blade. That would not be the best way to do it. The lasers allowed me to do those in my practice and manage there. But the laser is the right tool for many, many things. And it's not a procedure, but it's the tool that you want to use on a regular time. So as you look in your clinic, okay, you have many tools to use. Some of them you use on a regular basis, some of you don't. But consider the laser that you have, your Waterlase, as if you could hang it on your toolbar, that would be so much easier, wouldn't it? And then, I need my high speed, my low speed. When should I use my laser? The best solution I can have for you is never let it sit in the corner collecting dust. Always have it plugged in. Always have it in the room beside you, ready to go. Make sure it's primed. Make sure that it has a tip in it and that you're ready to use it because there's opportunities to use it. And if you remember what it can do for you, then you'll use it more and more. And the more you use it, then the more chances you'll see the better results that you're getting. And you can continue on and adding more procedures along the way. All right. So time for some sharing of questions. If you have any, it'd be great. And again, my apologies on my downloads today. I was quite surprised because I checked it earlier this morning and things were ticking along really well. This is my contact information. If you have any need to get a hold of me or ask any particular questions, you can reach me there. And at this point, Javi, if you want to open up the chat, see if there's any questions, I'm ready to go.
Yes, absolutely. We have the chat open. We do have, we did have someone's hand was raised, but see if there's any questions here.
Must be one or two.
Yeah.
None?
Oh, there we go. I'll let Dr. Abdullah is raising his hand, so I'll let you talk, Dr. Abdullah. Go right ahead. You just need to unmute yourself. There you go.
Go ahead, Doctor.
Yes, thank you for this amazing presentation. It was very insightful. However, I just have a question regarding if there's any specific recommendations according to the manufacturer instructions regarding changing the laser tips or the laser beam output or the number of, according to the number of applications, or how do I know that I need to change it or that it's overused?
Okay. Oh, fair enough. That's a good question. And so, because I think the integrity of the tip is by far the most important thing, and much more so with the gold handpiece compared to the turbo handpiece. Let me put it first of all, okay? The turbo handpiece, the tip is broader and you're further away from the restorations that you're working on. So they allow you to be used multiple times without any issues. Where we run into issues with tips is first of all, when you're changing, let's start at the beginning, is that when you're working on and you want to put a new tip in, the first step is to make sure that you've either purged your machine, or the shortcut can be is that you make sure the machine is in ready position and you have air coming out of your handpiece. That's so important. If you have not purged the system to dry out the internal part of the handpiece, make sure, and you forget, at least make sure that you have the air turned on and the green light is on. That will ensure that the interior of the handpiece where the mirror is kept dry. Because if you get water in there, that's going to change the reflection of the energy coming out of the fiber, and that'll cause some reflection possibly from the mirror back onto the fiber, which could cause some damage to the fiber. You don't want to do that. Okay. Or it may cause some damage to the tip. If you've ever had a situation where you've had a tip that didn't seem to be working so good, and you take it out of your handpiece and it's black at the end, that means water inadvertently got inside your handpiece, which means that you either changed the handpiece or the tip wrong. So that's step one. Once you've worked with the tip over time, with your loop, sometimes when you have a 3.5 or 4.5 power loop, you can look at the end of your tip. And if you start seeing the edges of the tips breaking down, that means the light isn't coming down focused straight anymore. It's spreading out. When it's spreading out, you're not having that focus going to where you want it to go. So it will slow down the tip because now you've reduced the amount of millijoule energy at the surface which you're cutting. So at that point, if you see, and another point, if you're working with a tip and you see a lot of sparking, that means that the energy is coming back onto your tip. It's getting reflected on that tissue that you're working with, and that breaks down your tip faster as well. So you may not want to use it again. So if you ever find that you're working with some tips and you find that they're working really well, and then all of a sudden they're slowing down, and you go, oh, what's going on here? Then my suggestion would be is to immediately take that tip off, put a new tip in, put that old tip to the side, and then either teach your staff how to analyze the tip to see if it's in good shape or not. Does that answer your question?
Yes, thank you very much.
Excellent. On to the next question here. Is there any concern with debonding a core under a crown/veneer?
100% no. That core cement is very deep. And then, so remember now what's happened. So as the energy is being absorbed through the crown, at that point, once it hits the cement layer, it spreads out and it breaks down that, because laser energy not only looks for water, but it also looks for the path of least resistance. So as the energy goes through, it kind of spreads out. And so then it's breaking the bond down without penetrating into the core. Now, however, let's say you wanted to get a post out. Same technique is being used. It could be a metal post, it could be a fiber post. If you want to remove that post, well, now we're going to use the energy of the laser to go around the post, keeping it basically in line with the post so that we're going longitudinally. We're not cutting into the post, we're not reflecting off the post. We want the energy to go down. Energy is going to find the path of least resistance there, which is the cement layer, and it's going to break down that cement layer. And then you kind of grab on with a bit of a tool and start twisting it, and out it comes. Takes post out extremely well when you have no core to work through.
All right. Next question. Do you anesthetize all cases?
Well, that's a tough one. If I am, I guess it depends what I'm doing at the end. If I'm going to be prepping the teeth, I'm going to anesthetize anyhow, right? If I'm doing a tooth that has an endodontic tooth and I want to remove the crown and do something with it, no, I don't need to. I don't need to do that. I really that always depends on the patient. If what and manage if I'm doing non-anesthetic work, and normally if I'm removing veneers, I'm taking them off for a reason to replace them. So I am using anesthetic at that point. If I've had one that didn't bond well, and maybe I have a dark space in it, maybe at that point, I've removed those without any anesthetic. But again, it's very patient dependent.
All right. Thank you. Any other questions out there? We have a few more minutes.
Yes. Well, again, thank you all for listening. It's been good. And managed from there. You do have my contact information. If you have anything specific, if you're a little shy to talk, just message me and I can answer you very quickly.
Yes, and I'm getting questions. If you can see the recording, it'll be on our website probably within 24 hours. So you can just go to biolace.com and you can go on webinars and you'll see the recording there. But please give it about 24 hours for our technical team to look on there.
Yeah, and maybe what I'll
Oh,
do,
yeah.
Javi, is I will send over a copy of this, and so they can upload it so that it doesn't so that the videos are more streamlined.
Yeah, absolutely. No problem. And thank you everyone. For those that are on here, you will receive a survey tomorrow. Once you complete that survey, you will receive your CE credit. But please give it about again 24 hours or so for that to happen. So, but if there have any questions, my name is Javier. I'm the one who's been sending you the web link and everything to make sure you're on here. So, thank you for joining.